Thank you, Brian. What I'd first like to do is thank Brian for putting on a great year of Grand Rounds. I think this is his first time as the director of the course. What I'd like to introduce now is our Grand Rounds, which we've titled A Clinical Pathologic Correlation in Pain Medicine Testing. This is a direct response to a Grand Rounds that was given, I believe, a year ago, maybe 2 years, from the genetics group here, where it was, I thought, a fantastic way to show what we're doing in the department, and that time on genomics testing, looking at cancer and inherited cancer syndromes. And because it was such a, that area is such an interesting both analytical and interpretive adventure, I thought to myself, well, hey, we do multiplex testing, we do quantitative molecular multiplex testing, and we have some interpretive skill too that I'd like to showcase. So that's where the genesis of this is from. Myself, I'm Geoff Baird. I'm the Director of Clinical Chemistry at Harborview Medical Center, an assistant professor in the department, and actually now the Director of Laboratory Medicine at Northwest Hospital. Andrew Hoofnagle, who will be speaking, is the Director of Clinical Chemistry here at the University of Washington. And Joshua Hayden is our Clinical Chemistry Fellow, and in a month, will be employed as a clinical chemist at Cornell University on the Upper West Side of Manhattan. So we have a team, and what we're going to do is, first of all, here are our financial disclosures. We will be telling you about the clinical problems that are associated with opioid use and misuse. We'll talk to you about what the testing that we do is. We'll talk a little bit about the metabolism. This is quite complex metabolism, which is why we're standing here. It really helps to have, we believe it helps our clinicians when we help interpret these results based on our knowledge of this metabolism. We'll talk about some clinical pearls that you should be using when you're thinking about these results yourself in your own patients. And then we'll talk about risks for opioid misuse. And I'll also draw on some other experience I have. Some of you may know that I'm actually serving a term right now as a federal grand juror. And so I'm going to talk a little bit about some of the criminal consequences of some of the problems with this type of testing. I bring this picture in to sort of initiate you all into what are the problems that we're dealing with, some common misconceptions. This man here is not actually, he's not holding any heroin. A lot of people think that we get all the heroin from the poppies. So those poppies contain opium, and heroin is actually not a natural product. It's a synthetic product made by this man, Felix Hoffman, who also invented aspirin. And he's not the first person to synthesize it, but he was the first person to make it commercially viable. That's heroin there in the original Bayer medicine jar that it came in. It was intended to be synthesized as a non-addictive version of morphine. Didn't work out. They thought they could make codeine out of it, and they ended up acetylating it. And another thing I want to bring in is just the scope of the problem, and I'm going to stop after this and then bring in Josh. But take a guess for yourself what you think the answer to this is. How much oxycodone is really out there? Is it 1 million 80 milligram tablets? I'll have you know a Percocet is oftentimes 5 or 10 milligrams. So an 80 milligram tablet, if people in this room are naive, would probably kill you. Okay? So how many are out there? Millions, 5 millions, tens of millions, 100 millions, or 1 billion? It's actually 1 billion 80 milligram tablets a year that we're making. Okay? Huge amounts. And also note that the US consumed almost all of this. And actually almost over 90% of all the Vicodin, the hydrocodone. Context is very important. I want to make things very concrete for you. The amount of oxycodone we make is actually the same weight as the amount of onions consumed in the Philippines, and it's twice the weight of all the gold in Fort Knox. Okay? Huge amounts of this drug. The amount of methadone that is made in this country is also preposterously large. If all the methadone that we use in this country was divided up finely and taken away from the people who were giving it to, divided into equal doses, and then fed back to the rest of the population of the United States, it would kill us all instantly. That's because you become tolerant to the drug and they're taking more than a naive person could consume. So there is an enormous amount of this stuff out there, and I'll introduce Josh now to talk about the consequences.
So Jeff spoke about the amount of opioids which are available. And the reason we actually care about that is because we're seeing this strong correlation between the amount of opioids which are available and the amount of people who are overdosing and dying on these and being admitted into our emergency departments for treatment. So what I'm showing here, if you look on the y-axis, I have the relative rates, and on the x-axis are the years. And you can see that as increases in opioid sales in terms of kilograms per 10,000 people have increased, the rates of opioid-related deaths per 100,000 people and opioid-related treatment admissions have tracked right up with it. Now, in addition to this correlation between increasing amounts with time, we're also seeing a geographical correlation. Some of you may have seen this map before. What I'm showing is a map of the United States with the kilograms of opioid pain relievers used per 10,000 people in the yellow circles. The larger the circles, the more kilograms of opioid pain relievers used. And I'm also showing the age-adjusted death rate per 100,000 people. The darker the blue, the more people are dying. And you'll notice that in regions of the countries which have low rates of kilograms of opioid pain relievers used, they also have low age-adjusted death rates. And just to further put it in perspective, during the 60 minutes which we'll be talking with you today during this grand rounds, there will be 2 deaths on average from opioid-related overdoses. There will be 57 hospitalizations and about $8.3 million in healthcare costs during this 60 minutes. In addition, about 220 people are going to use a non-prescribed prescription painkiller. So this is what's happening nationally. When we start to look locally, the problem doesn't get any better. This is data which I presented at our recent Eclipse presentation, done in collaboration with Geoff Baird and our medical examiner, Richard Haroff. And if we look at the top 5 drugs which caused drug overdoses in King County in the year 2010, we find that 3 of those top 5 are prescription opioids. And then if we look at our list of top 10 drugs causing overdoses in our local emergency department, we find those same 3 drugs on the top list. This is opioid-related mortality and morbidity right in King County. So what are folks doing about this problem? Some time back, Washington started the process of introducing new legislation on chronic pain. This was partially spearheaded by Dr. Alex Kahana, right here from UW. It was passed in the 2010 session and became effective January 2nd, 2012. This legislation has a lot of new roles placed on chronic pain patients, and in particular, they apply to opioid treatment for chronic non-cancer pain. So it sets dosing criteria. Patients who are receiving a morphine equivalent dose greater than 120 are described as being at high risk. So this morphine equivalent dose is something which you'll often hear us abbreviate MED. The different opioids have different effectiveness, and so we try to express everything in terms of milligrams of morphine. In addition, some of these regulations require specialty consultation with pain specialists, as well as tracking clinical progress, and finally, tracking opioid usage, the so-called compliance monitoring, which has spurred a lot of this discussion. When we talk about compliance monitoring and its goals in chronic pain, we're really talking about 2 things. First, we want to confirm that the intended medications which the patient is prescribed are present in the patient's urine. Second, we want to confirm that unintended or illicit medications are not present. And I'll point out that these goals are slightly different from routine toxicology. In particular, we're trying to monitor therapeutic levels of these drugs. As is somewhat surprising for big government legislation, while they passed this legislation, they didn't give any guidance on how to actually track opioid usage or do this compliance monitoring. So how do we do that in the lab? So the best way to go through it, I thought, would be to start with some case examples. First one, we have a 37-year-old female with chronic ulcerative colitis-associated joint pain who had recent pain exacerbations. Her pain is managed with hydrocodone, 5 10 milligram tablets a day, as well as fentanyl administered through a transdermal patch for 62 micrograms an hour, giving her a morphine equivalent dose of 205 milligrams a day of morphine. She submits a random urine, and we screen her with a point-of-care immunoassay, shown here, which detects the 10 drugs listed, and we end up with a positive opiates and a positive oxycodone. So how do we think about this? Is the person taking non-prescribed oxycodone? Are they abusing? And what about her prescription fentanyl? Is she diverting that? So in order to understand this, we really need to understand how these testing methodologies work. This first immunoassay which I showed you, which we use heavily in our lab, is a lateral-flow immunoassay. Anyone here who's ever seen or done a home pregnancy test is familiar with these assays. What we'll do is we put a drop of urine on an absorptive pad, which contains the drug of interest conjugated to gold nanoparticles. The drug and the drug-bound nanoparticles flows up the strip where it reaches a capture site that contains antibodies to the drug of interest. If the urine does not have any drug, then our drug-bound nanoparticles stick to those antibodies and we see a line. So in this case, a line means negative. If, however, there's drug in the urine, it can outcompete those drug-bound particles for the capture antibodies, and we won't see any line. These assays are point-of-care devices, which are CLIA-waived, and they're widely used in a lot of doctors' offices. From our perspective, it's very difficult to automate these, so there are two additional methodologies I'd like to discuss. The first is enzyme-multiplied immunoassay technology, or EMIT. This is what's used here at Harborview. In this case, we have an enzyme, glucose-6-phosphate dehydrogenase, which has been modified to have the drug of interest bound to it near the active site. So then when we mix this with the patient sample and the antibodies, if there's no drug present, the antibody will actually bind to the drug bound to the enzyme and inhibit the enzyme. If, however, drug is present, the antibodies bind the drug in the patient's urine and the enzyme is active. That way, the level of enzyme activity directly correlates to the level of drugs in the urine. An additional technique, which is somewhat different but in many ways similar, is known as cloned enzyme donor immunoassay, or CEDIA. In this case, we have beta-galactosidase, which is a multimeric protein which will spontaneously self-assemble into an active form. And we modify one of those polypeptides to contain the drug of interest. Then, when mixed with the urine and antibodies, if the drug is absent, antibodies will bind to that drug and inhibit the assembly of the active enzyme. If, however, drug is present, the drug binds the antibodies instead, the enzyme is able to assemble, and we have active enzyme. It doesn't matter which of these three assays we're talking about, they're all going to be immunoassays. They all rely on detection of an antigen by these antibodies. Or to use Russ Grant from LabCorp's analogy, what we're really talking about here is a handshake. It's a handshake between a small molecule and an antibody. So how good is that handshake at recognizing these small molecules? What I'm showing you in this table are the positive and negative predictive values for three common opioids, the opiates, oxycodone, and methadone, for the three assays which I told you about, lateral flow, EMIT, and CEDIA. I'll point out that the data for the CEDIA was provided by a clinical chemist, Carol Lynch, out at UCSF. And what you'll notice first off is that the positive and negative predictive values vary wildly, both between analytes. So let's take oxycodone by the lateral flow, which has 61% positive predictive value, versus opiates, which is 89%. And it also varies between the different assay methodologies. So while lateral flow is 61% positive predictive value for oxycodone, the EMIT has 95%. In general, though, you'll notice for the most part, the positive predictive values are going to be substantially lower than the negative predictive values. And this is because those positive predictive values have a lot of cross-reactivities, which can cause our so-called false positives. In theory, the manufacturers are supposed to account and address these false positives. And that's why they make a lot of claims over what will react and cause these false positives. So I also want to point out the importance of verifying manufacturer claims. So our lateral flow device, which is made by a company, ABMC RapidTox, states that it does not detect 7-aminoclonazepam. This is the main metabolite of clonazepam, a relevant benzodiazepine. And yet, when we take 10 patient samples who are prescribed clonazepam, who test positive in our immunoassay for benzodiazepines, and we analyze them, this was done in collaboration with the clinical chemist, Judy Stone, out at UCSD, what we find is that while 2 of them do contain other benzodiazepines, which could cause the positives, 8 of those 10 only have the 7-aminoclonazepam. So that brings to mind that old adage, trust but verify. And you can't really blame the manufacturers for this, because when you're talking about immunoassays, we're looking at antibodies, and different lots of antibodies can actually change from lot to lot. So this is data which Dr. Hoofnagle and I published recently in Clinical Chemistry, where we looked at the lot-to-lot variations in our immunoassays for these 3 opioids, looking at the rate of false positive or negative expressed as a percentage. And what you'll notice is that even though all 5 lots tested roughly equal numbers of samples, with similar numbers of samples being positive for the 3 drugs tested, the rates of false positive and false negative vary wildly. So methadone, for instance, 4 of the 5 lots average around just under 5% false positive, and then 1 lot approached 20%. Oxycodone, we had 1 lot with a false negative rate under 1%, and 1 with a false negative rate approaching 15%. And what I want to point out when we're talking about this data is that there are clinicians right now in our state and across this country who are managing their patients based on the results of these assays. We have patients testing positive for methadone who are then being terminated from pain contracts. And this should worry all of us. And I think we have to ask ourselves, do we have something better to offer our clinicians to monitor compliance in these patients? And with that, I'll introduce Dr. Hoofnagle.
Thanks, Josh. Sorry. Before I get going, this is Josh's last presentation here in the Department of Lab Medicine. He's been an outstanding fellow. He's also been a great colleague. We wish you the best. We're very proud of you. So I spend a lot of my time worrying about immunoassays. I think all of us do. And we wonder, Josh has already pointed out, how do they affect our patients? We use immunoassays regularly in the chemistry laboratory to help guide patient diagnosis, prognosis, as well as therapeutic management. And I think all of us could potentially lay awake at night and wonder how good we're actually doing. And I'm going to give you some data that suggests, I mean, he's already given us a little bit of data that makes us, maybe we should lay awake more than we actually do right now. But we do have a solution, and I'm going to talk about mass spectrometry. So using these data and saying, okay, there's plenty of false positives and plenty of false negatives, and in fact, we won't know when we break open that new lot of reagent how good or bad it's going to be. And so that should worry us, and it makes us frustrated. But let's go back to this patient, a 37-year-old female who's supposed to be on hydrocodone and fentanyl. This is a pretty substantial amount of morphine equivalents that she's taking, that she's being prescribed. And as Josh mentioned, the opiates are positive. Well, does that mean she's taking her hydrocodone and nothing else, or is she taking hydrocodone and everything else? Right? She could be positive for any number of opiates. And the oxycodone, well, now we have to kick her out of the program because she's not supposed to be taking oxycodone, but this is positive. So this has real implications for this patient. But I guess what I want to say is that we might be asking antibodies to do too much. So anybody in the middle rows or anybody in the back row, it's going to take you a little while to try to figure out what's different between each one of these molecules. But once you figure it out, you'll say, okay, well, I got those two. Now how is it different from that other one? It'll take us a long time to try to figure out how these molecules are different. And that's the part of the problem with immunoassays, trying to detect small molecules and differentiate them from all the other small molecules. This is the reason. This is the surface of the antibody binding site. So we have all of our amino acid side chains reaching out and trying to make a pocket that the little itty-bitty molecules will fit into. And for hopefully you can actually see that little molecule right there. That pocket is supposed to be specific for that little molecule. And, well, I mean, we've already looked at these molecules. I sort of liken this to an antibody walking around and saying, where's Waldo, right? And we're trying to tell the difference between where's Waldo and Waldo with and without a hat. And I got to be honest with you, I'm not very good at where's Waldo, and I think antibodies are actually worse at where's Waldo than I am. So I'm going to talk about LC-MS, liquid chromatography and tandem mass spectrometry. And we're going to talk about how we separate molecules, the molecule that we're interested in, from all the rest of the junk that we're not interested in. And we get to start out first with liquid chromatography. Chromatography, the separation of molecules from one another using a solid phase. So here I have a picture of a chromatographic column. They're pretty fancy these days. They're not like the things that we used to use back in the 80s. And we have an autosampler vial. We can dip into the autosampler vial, inject the sample onto the chromatographic column, and then flow solvents, both aqueous as well as organic solvents, across the chromatographic column and separate molecules over time. So we can separate them temporally from one another. And what we can do, as these things are eluting off of the HPLC, or the liquid chromatography column, is we can ionize them. And so this is a picture of the end of the tube that the HPLC stuff is coming out of. There's a tube within a tube, and the tube in the middle, the liquid is coming out, and then we blow some gas around that inside tube called the sheath gas. We put a huge voltage differential between the end of the HPLC flow and the instrument, the mass spectrometer over here. This little thing, I've blown it up, and you can see these little circles are actually charged balls. And so there's charge, and as the solvent evaporates because of the sheath gas, those charges get closer and closer together. Charges don't like to be near each other, and they explode. These are called Coulombic explosions. And pretty soon, you have a charged analyte, or many charged analytes, sitting in the gas phase, and they float right into the instrument. Once those ions get into the mass spectrometer, we can use different quadrupoles. These are mass selectors. So we can set the first quadrupole, this mass selector, to allow one specific precursor mass to charge ratio to make it through. Everything else will be excluded. Once that, for instance, if we're looking at the green molecule here, gets into the collision cell, we can break that into its pieces, and then we can set the second quadrupole to select for only the fragment that we're interested in. So now we have the selectivity of knowing the precursor mass to charge ratio, the selectivity of knowing the fragment mass to charge ratio, and anything that makes it through the first quadrupole and then again through the second quadrupole after the collision and hits the detector means it has the right precursor mass, the right fragment mass. And if it comes off the HPLC column at the right time, we now have 3 dimensions of specificity. So we're no longer playing where's Waldo, we're telling you exactly where Waldo is. So just to think about this, we're measuring 4 things at once. We could be measuring hundreds of things at once. And what we really do is we're not measuring everything at once. We're spending 25 milliseconds looking for the blue molecule, and then we might spend 25 milliseconds looking for the pink molecule, then the orange molecule, and the green molecule. So we're taking a little bit of time studying each individual channel. But what that looks like to us, our mere mortal human beings, is that everything is happening all at the same time. And we're collecting data on all 4 channels in about 100 milliseconds, which we can't really tell. So it's super fast. The other thing that I'll point out is now that we're able to look at different channels, we can use internal standards. And these are stable isotope-labeled internal standards that allow us to differentiate this molecule from this molecule. And they're chemically identical. In other words, they will separate chromatographically identically. But once they get into the mass spectrometer, because they have extra protons and electrons, we can actually tell the difference by mass. So here we can use an internal standard, an isotope-labeled oxycodone molecule, as an internal standard for this. And we can compare this peak area to this peak area to get a ratio and use that in the quantification of oxycodone. And at the same time, in the same assay, we can include this internal standard for methadone. So mass spec, using this fancy instrumentation, we're able to get now, instead of the word opiates, we're able to get all of these fantastic analytes, which now includes, and we're going to talk more about the metabolism of some of these molecules, codeine, hydrocodone, oxycodone, lots of different drugs and lots of different metabolites. And what we're able to provide is more granularity to start asking that question, well, is she really taking her hydrocodone, or is she taking everything? Well, this is what the immunoassay detects. So if we take this list and we narrow it down, what can the immunoassay detect? We only get 5 things, and that's kind of boring. So I think this is exciting, and I think this is boring, just to be clear. So this, I wanted to go a little bit into how is immunoassays, or how are they different from LC-MS, because I think it's important for us to think about on a daily basis. And well, I mean, think about the immunoassay. This is reliable. It's easy, it's simple, it's cheap. We can do it in our laboratories pretty quickly and without too much trouble. LC-MS it's harder to do. It's a little more complicated. It's fancy, and they sure do look nice. I liken the difference between immunoassays to mass spectrometry, much like a 1995 Ford Escort station wagon versus the Batmobile. Now I'm serious. So the Ford Escort station wagon is a fantastically reliable automobile. This has been in my life for a long time now. It gets me around from here to there. But you know when you're driving in Seattle that you're annoyed sometimes with traffic and you wish you had the Batmobile. You tip it up on its side and you drive. You do all sorts of fancy things, right? Well, I will stress the practicality, because you can't do this with the Batmobile. There are 39 2x4s in my car, and they went 5 miles. So a 19-year-old car can take 39 2x4s 4 miles without cracking in half. And some of the noises it made when I was taking this trip, this is just this past Sunday, I really did think it would break in half. But again, a perfectly reliable automobile. Now, unfortunately, this car sprung a leak about 3 years ago. And in Seattle, that's a problem, especially in the wintertime because it rains. And so enough water got into the car, and there's enough humidity in Seattle that it's fascinating. Things started to grow in my car. So this is a plant. This is actually a plant on the passenger side floorboard, and I've zoomed it up here. My car turned into a terrarium. So again, I think again very practical automobile, but it has its issues, much like immunoassays do. But I mean, we really do we use immunoassays a lot for screening purposes. We do a lot of diagnosis with immunoassays. I don't think they're the worst things on the face of the planet, but I think LCMS has something to complement, and in many cases, we'll be able to replace immunoassays, and we already have for many assays in the clinical laboratory. The things that LCMS offers: sensitivity. So the cutoffs that we can use in the opioid assay that we're talking about today are somewhere between 10 and 200 times lower than the immunoassay, and this comes from signal to noise. The reason is we can tell the signal away from the noise, where we can't see that. We can't tell that in an immunoassay. We're able to detect things like fentanyl and buprenorphine and meperidine at very low concentrations, which is what we need clinically. The specificity, I've shown you, we have 3 dimensions of specificity. We can provide granularity for the clinicians now to give them the answers that they really need. And as I'll talk about, we're going to avoid reporting false positive results. This is a confirmatory test. If we say it's there, it's really there. However, lots of data is hard. It can be confusing. And so what we do is actually sign these out. We actually provide an interpretation with every one of these. And if we have all of the patient information, in other words, go into the charts, which is what we're doing for many of our patients, we're actually able to provide a full interpretation in the clinical context of the patient's care. I mean, LCMS is not perfect, and I wanted to talk about a couple of the ways that we know it's not perfect, and what I want to brag about is we can tell you when we're not right, or when we can't give you the right answer, and that's what I want to talk about over the next couple of slides. So one problem we have, I mean, we're playing the Where's Waldo game again here in our head, but now let's be a mass spectrometer and try to say, where's Waldo? And the answer is, some of these molecules have the same precursor mass, and some of these molecules have similar fragments to one another. And so, for instance, these guys are all going to make it through the first quadrupole together. And so we either have to separate them by HPLC, or we're going to have to do something a little more clever. And so each of these groups have the same mass-to-charge ratio of the precursor. So the way that we differentiate them is actually by looking at multiple fragments of the molecules. So this is the first fragment that we're quantifying on. Again, different channels in the mass spectrometer. We can quantify this fragment, and this is what we expect to see if all of a sudden we have a sample that's this fragment is, where did all that signal come from? And this ratio is totally wrong. The ratio of this peak area to this peak area is totally wrong, which means that there's something interfering. I can't tell you what, but at least I can tell you that I can't give you an answer. Now, the immunoassay, you can't get that information. All you get is some wrong answer. So this is great. I can at least tell you that I know I will be wrong if I give you a number and instead not give you a number. The other problem that we have is something called ion suppression, which is a form of matrix interference. Matrix interferes with all assays, including immunoassays, but it also interferes here. So I showed you before how we ionize things and get them into the instrument. We have to put a charge on the molecule, and it turns out that things will compete for charge, more specifically phospholipids, proteins, and salts. They will grab onto that charge and not let your analyte of interest have the charge it needs to float into the mass spectrometer. Well, that means that we could have a potential false negative. And the problem here is if you get a negative sample, you won't, in an immunoassay, if there's no signal, you don't know if it's really negative or if there's something interfering. Well, in mass spectrometry, we can. We have that internal standard. And if something is suppressing the ionization, if something is competing for the ionization of our molecule of interest, this will actually become flat. And we can ask ourselves, well, where did all that internal standard go? It doesn't matter. We'll tell you. There's an interference in the substance, and we can't give you the answer that you want. Again, in an immunoassay, you'll never know. So we're able to incorporate these things into the quality control, as quality control parameters in our LCMS experiments. And one of the things that we do is spike in many cases, we spike in a molecule to see if we can actually detect it. And the reason that we do this is we don't have isotope-labeled internal standards for every molecule. And so instead what we do is we add an analog internal standard and use that to evaluate for ion suppression. Some data that Patrick Matthias has put together and is actually submitted for publication shows that these are just peak characteristics, signal to noise, as well as relative retention time. I won't talk about those, but we can rule out some things as being false positives based on those. The internal standard peak area we're using to identify ion suppression, and when we use an analog internal standard, we can again rule out some of those. And then the ion ratio, that's talking about fragment 1 versus fragment 2. So in a lot of cases, we can actually throw some false positives out. But if you use an analog internal standard instead of a conventional internal standard, which is a deuterated or stable isotope labeled version of exactly what you're trying to measure, you can really avoid false positives and not need spike recovery experiments. What we're showing is that up to 3% in certain dilutions of urine may pass all other QC, but fail spike recovery. And so we've done this for more than 2,100 patients to really get the best handle that I think has ever been understood as to how important spike recovery and internal standards can control for potential ion suppression. So coming back to our patient number 1, who had an immunoassay result of positive opiates and oxycodone, knowing that she's on hydrocodone and fentanyl, when you actually look at the LCMS results, you get so much more data. It's so much richer. So we have hydrocodone and norhydrocodone, which is a metabolite of hydrocodone, and you can see the fentanyl and the norfentanyl, which norfentanyl is a metabolite of the fentanyl. But now you see hydromorphone and hydromorphone glucuronide, and you say, oh gosh, this 37-year-old female is doing bad things. Is she abusing her Dilaudid? Well, metabolism of opioids is very complicated, and I won't go through all of these CYP450 enzymes and other enzymes that help metabolize all of the opioids, but codeine can turn into lots of different things, as an example. Hydrocodone turns into lots of different things. So the metabolism is incredibly complicated, but we can actually boil things down a little bit and think about this case. Well, we know that hydrocodone was present, and we also know that almost all patients convert hydrocodone into hydromorphone. And so we know that if present in the correct ratio, that the hydromorphone is merely a metabolite of the hydrocodone. And the similar enzymes the same enzyme is responsible for converting codeine to morphine, just as an example. So, complicated metabolism, but if you know it, you can actually begin to interpret, and this is how this patient was signed out by Jeff. These results are consistent with the hydrocodone and the fentanyl therapy. We even go on to say that the oxycodone immunoassay was a false positive because it wasn't detected in the LCMS. And we even point out that hydromorphone and hydromorphoglucuronide are actually metabolites of the hydrocodone. That's it. So now a primary care physician can take these terribly complicated data and actually treat their patient appropriately instead of flying in the dark, which is what I would argue they're doing with the immunoassay. Patient number 2 actually is a 79-year-old male who has chronic back pain from degenerative disc disease, is on oxycodone, both long-acting and short-acting. The idea of long-acting is that we can stably have the patient receiving anti-pain pharmacological therapy, and then the short-acting, which is more addictive, for only those breakthrough moments. Immunoassay shows up both opiates and oxycodone again. Wait a minute, that's the same immunoassay result that we had from patient number 1, but a completely therapeutic regimen. We wouldn't really know what to do about this opiate positivity because oxycodone shouldn't cross-react in our opiate immunoassay. And we run the LCMS. We're looking at oxycodone, oxymorphone, and oxymorphone glucuronide are all oxycodone metabolites. But that means hydrocodone. Is he abusing hydrocodone? And that's the concern that we might have with these LCMS data. But we know that there are lots of impurities, pharmaceutical preparations are actually contaminated. We've put together this list here of the impurities that are expected from each of the pharmaceutical preparations, and you can see these are low, 0.1% to 1%, but when you start to take milligrams of something, you're looking for nanograms, you can begin to see those impurities. And so actually, this isn't hydrocodone abuse. This is actually the hydrocodone that's present in the oxycodone that they took. They're actually doing exactly what they're supposed to, and we're able to see it in their urine. These other problems, well, what about the codeine and the codeine? What are all these interferences? Does that mean that they're pouring some soap into their urine before? I mean, he is 79. I doubt that that's happening. But can we? What's explaining? How do we explain these things? So the codeine and the codeine 6-glucuronide is always interfered with by oxycodone because there's an oxycodone metabolite that Jane Dickerson, who's in the audience and from Children, spent a lot of time trying to figure out what it is about the oxycodone metabolite that interferes with codeine. We were never able to figure it out. So we're still left with patients who take a lot of oxycodone. We can't tell if they're taking codeine or not. And the morphine 3-glucuronide, this is just something that is causing ion suppression. It's a matrix interference, and there's nothing that we can do about it except tell you we're never going to be able to give you an answer, which again is completely unlike any immunoassay. So that's it. To summarize again, LCMS is more sensitive. It is more specific. It provides more granularity and allows our primary care physicians to take care of our patients better, but it can be confusing, and so the interpretation is something that we're proud to help them with. Back to Jeff.
Okay, thanks, Andy. I'm going to move on to some other cases where the clinical interpretations are more on the naughty side rather than the nice side. And we'll talk about how we do that. So this is I might add that these are all cases that we've seen actually quite recently. This is a 36-year-old male who has prescriptions for hydromorphone and a fentanyl prescription from some time ago. And the immunoassay result gave us opiates, oxycodone, and cannabinoids. And our LC-mass spec data is what you see there. There's hydrocodone and fentanyl. Now, we saw in the last ones, hydrocodone, most people make hydromorphone from that and hydromorphone glucuronide. Most people also make norhydrocodone from that. There ain't any there, okay? And then fentanyl is very rapidly metabolized to norfentanyl, but there ain't any there. So what do we think is going on? So one of the things that people do, because you read about it on the internet, is that you think, well, if you're actually not taking your drugs, maybe you're selling them on the street or something, but you want it to look like you are, you put a little pill in your urine. So medical testing is different than police testing, workplace testing, where it's not usually directly observed, and people can usually get away with dropping a little pill or maybe a little bit of their patch or something into their urine, swishing something around. And it will test positive on as you can see, it tested positive on the immunoassay. You'd be lost if you didn't have this information, because we now know that there's no metabolite. So that's really fishy. So what I'm going to tell you about is our thought processes during the sign-out process, how we actually do this. And for those of you who know me, I really like to think as a Bayesian. So what we're going to do is we're going to start with the pre-test probability of how likely is this person to be cheating. So we know from our own literature, our own data and the literature, that somewhere around 20 or 30% of people who are getting this testing have some evidence of cheating in some way. Not necessarily this type of cheating, but the overall prevalence is substantial, actually. So that's where we are. And then what we have to do is we have to start modifying, using that pretest probability, modifying our thoughts about it based on all the things that we know about the various different metabolisms and the possibility of these results happening. So could this person be innocent, actually just ran out of their hydromorphone and just took what they had lying around? This was an honest person who just sort of needed some pain relief. Well, that does happen. Doesn't really explain the weird no metabolite results, but whatever. And then we also have another explanation, hearkening back to our last year's genetics presentation, when genetics influences this. You saw in Andy's presentation for the different metabolites that if you're missing or have different mutations in your cytochrome genes, you may not be able to metabolize and make those metabolites. So let's now talk about the negatives. Well, honestly, it's most likely, we see all the time that people add drugs to their urine to pass their test. One of the things that's more likely is that it's usually what we see when this happens, or sometimes what we see is ridiculous concentrations of the drug. So people don't know exactly how much to put in. They just put a whole pill in or something. And maybe this guy just got lucky. I think he probably just got lucky, but maybe that can be on either side of balancing us, that well, maybe it's more favorable or less favorable that he's cheating. And last, he probably doesn't know that we could tell hydrocodone and hydromorphone apart, so maybe that's why he did this. Other reasons to support that he may have not been really cheating is that people do run out of their drugs all the time. People who are, people that are addicted to these substances, so people take them a lot. People sometimes take their old prescriptions. And then another piece of evidence that suggests that this was okay is that he had a previous result that was nearly identical. Okay? So people sometimes aren't, I wouldn't say maybe dumb enough to try the same foolish thing again, but if he didn't get caught the last time, he's definitely going to try it again. Then again, if it was a metabolic issue, you would expect that to be permanent for his whole life. So you'd expect that that would be constant, and so that maybe weighs more towards him actually having some metabolic problem. But really, on the cheating side, a lot of our patients exhibit noncompliance. And when we actually think about the enzymes involved, fentanyl is metabolized to norfentanyl by enzyme 3A4. The other conversion, hydrocodone to hydromorphone, is 2D6. The poor metabolizers are just a low fraction of people in the population, and the fraction of people who are doubly knocked out for both of these things is the frequency of one times the frequency of the other, so vanishingly unlikely. So that makes it much less likely that he probably has a mutation or many mutations causing for this. So this is actually how I think about these things. The redness of this, of the thermometer, is sort of his likelihood in my mind for cheating on this. And I start off with the population frequency, and then I think, well, maybe, it happened before. Maybe he really does have a mutation that's causing this. But, the mutation's really unlikely. And, honestly, people do these things a lot. And that's a very unusual way. Most people would not be, you would definitely see some other metabolite. And besides, he had no evidence of the actual drug he was supposed to be taking. So this is the result that I ended up giving. And we can get fairly verbose on these things, because these things have medical complications that can reach into the legal sphere, too. So I ended up saying that hydrocodone and fentanyl were identified in the absence of any metabolites. This same unusual finding was noted in a prior screen. And at the concentration that the analytes were present, the patient would need to be almost totally deficient in 2, if not more, metabolic enzymes. They would have also have to have been unable to glucuronidate things, which is very unusual. And for this to be a physiologic, as this would be exceedingly rare and in fact has essentially never been reported, the most plausible interpretation is that it's been adulterated with pharmaceuticals. Moving on, another one. This is a very common finding. A patient who's a 59-year-old female who has chronic back pain from degenerative disc disease and is on oxycodone, a short-acting version, not a very high dose, and we detected nothing. Nothing, immunoassay, nothing. So what do we think is going on here? Well, I'm presenting this case to present the idea of diversion. And what diversion means is that someone actually gives their prescription to someone else, sells it to someone else, whatever. The person in whose mouth it ends up, or nose, or whoever someone chooses to use it, is not the prescribed patient, okay? So where do, and this is where my legal experience comes in, so you're going to see a little bit of that. Where do illicit opioids come from? It should be pretty obvious from what I've implied. Prescription opioids that are illicit out in the population come from prescriptions, okay? The doctors prescribe them, and then the patients do with them what they please. There's one other main place. There's 2 main places in the United States that prescription drugs come from. One is from prescription diversion, and the other one is Florida, okay? So we'll talk about Florida. So this is data from the CDC. Where are people? This is people who they've asked. Where'd you do your drugs? It's anonymous. Where did you get them from? 55% get them for free from a friend or relative. People are taking them from their parents, from their cousins, from their children, from their spouse, from their brother or their sister. For free, just someone's given them some of the stuff they have left over. Prescribed by a doctor is down there. Bought from a friend or relative. That's enterprising. Took from a friend or relative without asking. So theft is a way. And we oftentimes see in the medical records of these patients are asked to keep their drugs under lock and key, and then otherwise they may have gotten them from a dealer or a stranger, okay? And then the infamous other. This is data we've collected here. Quickly, what these are is the percentage of times where a drug is found in a problem case, in a case where there's been diversion or abuse. What we see is, in the red bars here, this is the percentage of the cases that we've seen here at UW that have been prescribed that medicine. So 35% have been prescribed oxycodone, and approximately 15% have been prescribed morphine, et cetera. Then the other blue bars are the ones we see are what's being abused. You notice how they tend to correlate? The pool of drugs out there that are being prescribed are the same pool that's being drawn from for illicit use, okay? Oxycodone diversion, I'm going to get to Florida here a little bit. In 2009 to 2010, the average pharmacy purchased 65,000 dosage units of oxycodone. The average in Florida was 1.2 million per pharmacy, okay? 40% of all of the oxycodone in the United States was sold in Florida. Do they have 40% of all the pain? Maybe. I wouldn't want to live in Florida. But it is a crazy problem there. The solution from the DEA, you may have laughed at some of the jokes. This is actually not a joke. They've actually asked people to come and just give them all back. They have drug turn-in events, and they claim that they have gotten at these events 100 to 400 tons of medication returned to them. I might add, because I've seen this in the legal sphere, whenever you see amounts of drugs reported by the DEA, understand that they always include the packaging weight. So if there's like an oxycodone pill sitting on a bar of lead, that was 40 kilograms of oxycodone, okay? So this is not 100 kilograms of oxycodone, okay? So that's one thing. Another thing that they've been going after is using what they call the Ryan-Haight Act. I don't know if anyone here who knows who Ryan Haight was. He's an 18-year-old who got Vicodin on the internet from an internet pharmacy, no prescription, no nothing, just sort of mailed to him, and he overdosed and died. And then by 2008, there was a law that basically said, listen, internet pharmacies are a problem. There's a felony if you're online trafficking these things. You have to have an in-person evaluation with a doctor. You can't just sort of go to a virtual doctor and be examined by email, which is what happened. And then all the online pharmacies have to register. So that was 2008. By 2013, of all the internet pharmacies out there, guess how many registered? 7? There's more than that on the internet. Internet's a big place. So that wasn't terribly successful at the time. But it caused enough of a squeeze that most of the internet pharmacies, which are almost all based in Florida, they went to starting pill mills, which are essentially doctors' offices where the doctors are selling drugs right out the front door. And then that became a problem because they were basically selling at street prices for people. They were just dealing. And so they passed laws in Florida that said pill mills have to get shut down. So this is the amount of oxycodone sold in the whole United States, and this is Florida, okay? Huge amounts. Now, bang, the law against pill mills, okay? So what's happening now? They've just opened up more brick and mortar pharmacies now. They figured the pill mill thing got caught. They're opening regular pharmacies. They're buying pharmacy licenses. The number of new pharmacy licenses has skyrocketed in Florida. And guess where else? Georgia. Where does Georgia border? They're just driving north. Okay, they're going to Mississippi, they're going to Georgia, they're going to Alabama. So there's something intrinsic about Florida. I don't want to get into it, what it is. But here is the summary that you need to think about diversion, and then we're going to finish the last case with Josh. Prescription opioids on the street come from 2 places. Your family and friends, hard to think about that, but that's true, and Florida, so stay away. And then there's risk factors that you need to look at, both at the pharmacy level, the patient level, and the physician level. At the pharmacy level, pharmacists have to pay attention to patients who come in with outrageously large prescriptions or a bunch of prescriptions all with the same amount or the same patterns, like they all want exactly the same number of oxycodones and hydrocodones, et cetera, or all the same diagnosis, like everyone has left leg pain on one day. That ends up happening. Number 2, at the patient level, if you see non-compliant urine screens, which we maintain you should be doing, that's obviously a big warning sign. And if there's a patient who doctor shops, that's a big warning sign. We have a prescription drug database in this country, in this state, but not all states do. And then finally, risk factors at the physician level. This is called the 4 Ds by the DEA. There are physicians who are deficient, just don't know that this happens. There are physicians who are duped, their patients are lying to them. There are patients who distribute these things deliberately, they're pushers. And then there are physicians who are fueling their own habits, they're drug dependent. These are the things that we need to worry about in our patients. So I will move on to the last patient here, and I'll leave it off to Josh.
So Jeff told us about the problem of diversion, and I'll talk a bit about the problem of abuse and also how those two are really intermixed. And I promise I'm going to leave time because I'd be remiss if I left my final grand rounds without a question from Dr. Cookson, which I always look forward to in the audience. So patient 5 is a 50-year-old female with multiple myeloma. She's on short-acting oxycodone and longer-acting, we would think of it as a methadone maintenance, with a morphine equivalent dose of 330 milligrams per day. The immunoassay screens positive for opiates, methadone, cannabinoids, methamphetamine, and cocaine. And we notice a number of opiate medications on her LCMS-MS. So I want to start by discussing this 6-acetyl morphine, and this is for the residents in the room, maybe an excellent rise or boards question. 6-acetyl morphine is actually the pathonomic metabolite for heroin use. If you detect this, your patient has used heroin. And in fact, it's a relatively short-lived metabolite. So in our patient's case, where we're seeing over 2,000 nanograms per mil, not only have they definitely used heroin, they have used heroin very recently. So what happens is heroin is diacetylated morphine, as Jeff told us in the beginning. It rapidly enters the central nervous system where it becomes deacetylated. The 6-monoacetyl morphine can then be further deacetylated to form morphine, which can go on to the various morphine metabolites. You notice in this patient, we also have the codeine. So what is that coming from? Well, as it turns out, just as there are pharmaceutical impurities, which Dr. Hoofnagle told you about, there are also impurities in illicits. In fact, they tend to be substantially higher. The process of actually extracting and acetylating the morphine yields a lot of codeine from the poppies. So since 6-acetylmorphine is relatively short-lived, some folks have discussed the presence of codeine or codeine glucuronide being a good indicator of heroin use. Now generally codeine goes to morphine, but if you see the morphine to codeine ratio which is greater than 1, that can be an indicator of heroin use. And in our patient population, in 24 samples which have tested positive for the 6-acetylmorphine, we see an average morphine to codeine ratio of 10. Now I will give the caveat that in conversations with Amedeo Pesci from one of these large reference labs, he has mentioned that there can be some overlap. Morphine to codeine ratios between 1 to 10 can overlap with codeine therapy, which is why I'm going to highlight the importance of having an experienced clinical pathologist interpretation and also Jeff's Bayesian approach to think how likely is it that this patient may or may not be doing heroin, and then giving that rather verbose interpretation so our clinicians are well aware of what it might and might not be. So in this patient's case, when we think about that heroin use and our Bayesian approach, it's certainly helped by the presence of methamphetamine and cocaine, which increases our pretest probability for use of illicits such as heroin. And I will also emphasize that with our current chronic pain testing, we use a screen reflex algorithm. So what happens is as soon as that immunoassay goes positive for methamphetamine, and remember I told you that while they have variable performance, in general their negative predictive values are relatively high. So we get that positive and we automatically do reflexive confirmatory testing. So in this case, we detected with a separate mass spec assay both methamphetamine and its metabolite amphetamine. And we also confirmed the cocaine with a highly specific immunoassay, which actually detects the cocaine metabolite, benzoacanine. So this patient was signed out as being consistent with heroin, methamphetamine, cocaine, and cannabinoid use, as well as their methadone therapy. And there's no evidence that the patient's prescribed oxycodone, which, as Jeff just told you, diversion is a major problem. You can sell your pills, you can purchase your heroin, your methamphetamine, your cocaine, and then whoever bought your pill can wind up in our emergency room with an oxycodone overdose. I do want to point out something else about this patient, though. You'll notice this is a multiple myeloma patient. So the regulations in our state specifically address chronic non-cancer pain. So where did this guidance come from? You would think there's a large New England Journal of Medicine article or some JAMA article which talks about chronic cancer pain patients not being susceptible to misuse. And if you thought that, you would be absolutely wrong. There's no data whatsoever showing that chronic cancer patients are any more or less susceptible to opioid misuse. And certainly when they misuse opioids, they are just as susceptible as non-cancer patients to the adverse effects. So with our colleagues at SCCA, we were able to obtain a cohort of just over 130 chronic cancer pain patients who were screened. This was based on their internal policies to test every patient who comes in to initiate opioid therapy. We also had just over 1,300 chronic non-cancer pain patients. And what I'm showing you here on the y-axis are the percentage of patients. The non-cancer patients in blue, we had larger patients. You'll notice the smaller, tighter, 95% confidence intervals, and the cancer patients in red. And I'm showing the percentage which were compliant, which had possible diversion, so that in absence of something they were prescribed, those who were abusing something, and those who were using illicits. And you'll notice that the compliance rates between non-cancer and cancer patients are statistically indistinguishable. If anything, there's a trend towards less compliance in our cancer patient population. And you notice the rates of abusing and the rates of illicit are actually somewhat higher. And one of our pain doctors, Dr. Fitzgibbon, likes to talk about the under-recognized psychological burden of a cancer diagnosis and how that can impact people who may have already underlying tendencies towards chemical dependency. But also notice that in many places in this state and all across this country, these patients who we're finding are abusing drugs, who need to have a conversation with their clinician about the dangerous behaviors they're engaging in, they're not having that conversation because they're not even tested, because they're not subject to many of these regulations. Which I think really calls into mind, how do our clinicians think about who's at risk for misusing opioids? So as it turns out, one of the most common tools is this thing called the opioid risk tool, where you give points for different factors, and then you determine based on the final number whether that person is high risk, low risk, or medium risk. So you can see we have age. Somebody in my age category gets a point. And of course, the Washington state legislation said anybody over 120 morphine equivalent doses at high risk. So how does that play out in the patients that we've seen here at the University of Washington? So these are those same charts looking at percentage of patients, compliance, absence, abuse, and illicit for 18 to 45, over 45, and the different morphine equivalent doses. And what we see is that neither age or morphine equivalent dose are a substantial risk factor for opioid misuse. Also in the opioid risk tool, personal history of substance abuse. This is something which we've looked at, and we found that it actually is a strong predictor for opioid misuse. Patients with a history of drug use, as mentioned in the chart, found through chart review, are shown in red, and you can see that they have under a 40% compliance rate, with the rates of abuse, and particularly abuse of illicits, being very high. Even their rates of absence are high. And this is important because other studies have shown that diversion of prescription opioids is strongly associated with the presence of illicit substances. These folks are using their heroin, they're buying it with the oxycodone that they're selling, which they're receiving from our medical communities. In addition, one of the things we can do with this mass spec methodology is we can look for additional markers. So when somebody ingests ethanol, it can be metabolized through a variety of routes, one of which will generate ethylglucuronide. Validation work by Patrick Mathias and Mike Schmeling allowed us to add this to our opioid assay so we can now detect levels of ethylglucuronide. And what we found were that levels of ethylglucuronide greater than 10,000 nanograms per mil. So these are levels which are not associated with a single glass of wine. This is substantial drinking. We're seeing a trend towards decreased compliance in these patients. And that combination of alcohol and opioids is a lethal combination. And in addition, you combine misusing your opioids, and it's much worse. So in summary, what we're really trying to do is we're trying to balance undertreated pain. We're trying to ensure safe access to prescription opioids to those patients who need it, with the potential for opioid misuse, which is a large and growing problem, both diversion and abuse. And I would make the argument that compliance monitoring through some of the methodologies, which myself and Dr. Hoofnagle have told you about, can help detect opioid misuse. And I think most important for everyone to know is that there is help. So clinical pathologist review of chronic pain screens are available through the University of Washington Department of Laboratory Medicine. So I welcome Dr. Hoofnagle and Dr. Baird up to join me, and we will certainly take any questions.
Well, first, we should
But
Thank you. And thank everyone.
And yes, certainly acknowledge the many, many people at both University of Washington and Harborview and SCCA who made this work possible. Drs. Hoffman and Mathias, and Dr. Bryant, who recently talked about tramadol, as well as the many, many medical technologists, a couple of whom are listed here, but Tom, Mike, Mary, Tracy, and many of the others who made this happen. And Patrick has an MD and a PhD, so I thanked him twice. And certainly at Harborview, Dr. Valento and Fred Wu and Lisa Lawrence, and then our collaborators at SCCA, clinical pharmacists James Gibson, Jennifer Jackie, and Dr. Fitzgibbon.
Thank you.